We move on to the next session in the program. This session is on imaging. We've got 4 speakers in this session, and I'd like to welcome the first speaker, Manu Jain, to the microphone. Manu is going to speak on non-invasive optical imaging for skin cancer. So welcome, Manu.
Thank you, Liam, for your introduction. Thank you. I would like to thank the organizers for their kind invitation. And I want to highlight I'm coming back to Singapore after 24 years. So it's amazing. I have to still see how it has changed, but I want to finish my talk in time. So my topic is non-invasive optical imaging of skin cancers from bedside to teleconsultation, a paradigm shift for wider integration. And I'll show you why I'm saying wider integration. My conflict of interest, and here. So in this talk, in like 15 minutes, I just want to touch base on certain things which you already know. We don't want to hear about it. Skin cancer incidence, current diagnostic methods and limitations. But why I'm talking about it is because we are going to talk about optical imaging devices and their role in skin cancer diagnosis and issues with wider integration. That's the main question here. And the last thing is obviously the most important is, can teleconsultation aid in wider integration of optical imaging? So we know skin cancer incidence, this is nothing new. Basal cell carcinoma, squamous cell, melanoma. These are the 3 main skin cancers. We also know early detection is curable even for a deadly disease like melanoma. However, late diagnosis lead to morbidity, increased morbidity, mortality, and also adds to treatment cost. Skin cancer, current diagnostic methods, we know, visual examination, followed by dermoscopy. So they're good, however, they have low sensitivity and specificity. This often leads to biopsy for histopathological confirmation. And I'm a pathologist, so I would say pathology is the gold standard and still is. Biopsy is an invasive procedure which causes pain and scarring, and people don't want to get biopsied on cosmetic sites such as face. 70-80% biopsies, actually they come back benign, good for patient, but bad also because they've endured that kind of anxiety, pain, and scarring and all, and they come benign, good news for them. And pathology, it's time-consuming, it's tedious, it requires an extensive lab setup, and I have my own research pathology lab, I know how much things we need to get the slides, And patient, look from the patient point of view. The patient has to wait for a week or even sometimes months, depending on where you are for the report. It delays management, but also increases anxiety. So here I'm transiting into a new era of imaging, which is called non-invasive optical imaging technique. So these techniques, there are many devices out there, and the main purpose is to avoid biopsy and its drawback. And also at the same time, you can visualize histology resolution in vivo at the bedside. This is the main thing with all the optical imaging techniques right now. I'm going to talk about only 2 optical imaging techniques to begin with, because these are the most commonly used in clinics currently, at least in the United States and in Europe. This is optical coherence tomography, which is something very similar, which people have been doing in ophthalmology, but in skin, it's not that new. It's 1990s something. But with OCT, which we call, you can actually see there is, actually I can use this. Yeah, can you see my arrow? Yeah, so you see vertical images. They're not cellular resolution images, but they're still pretty good. Here you're seeing a basal cell carcinoma tumor nodule. Both these devices, like optical coherence and reflectance is another device that we use extensively at Memorial Sloan Kettering Cancer Center. And both of these are very portable devices. And the most important thing which I want to bring in to attention is the monitor or the screen. And this screen plays a very critical role when you're doing teleconsultation. And that's what I'll bring later. So with confocal macroscopy, another device, which I use extensively at Memorial, I've been using it for 8 years, you see cellular resolution images. As you can see, this is an example of melanoma here. And both these devices give immediate bedside diagnosis if somebody know how to read them at the bedside. So how these devices have changed the clinical workflow. So initially people were coming, like the patient will come, there's a visual examination followed by dermoscopy. But now, before biopsy is being done, we send the patient for one of these optical imaging procedure. It can be OCT, it can be confocal, it can be both, depending on what you're looking at. And after that, a decision is made whether you want to biopsy the lesion or you don't want to biopsy a lesion. And that is very important. A recent study by Pellicani et al. Has shown that confocal microscopy, actually using this pathway, has reduced NNE dramatically. But right now, the limitation with all these devices is grayscale images. You saw these images were black and white. And also, when they have like cellular resolution, you need some histopathology training to read them. So reader is a problem currently with these techniques. And I joined Memorial in 2015, 2015, and I published this paper in 2018. I was very nervous. And at that time, I started looking at the images and I said, what's happening? What are these images? Black and white, AFAS? It doesn't make sense from a pathology point of view. But it took me 1.5 years, despite being a histopathologist, to learn. And still, I think every day is a new day for me. So these are difficult images for people to read. Now, so optical imaging we saw is making significant impact. We saw NNE has come down significantly. It is being integrated in clinics, but it's still, people are very hesitant to use it. And then teleconsultation, can teleconsultation rescue the situation? So the first method is of teleconsultation, we are all aware, is store and forward method, and that is happening. So in the store and forward method, a dermatologist would identify a lesion and send it for optical imaging technique, right? This microscope is mostly sitting in their clinics, or it can be sitting in some center. They can get it done, like a tertiary center. And after that, these images go to a cloud, and from there, they are sent to an expert reader sitting anywhere in the world, right? It can be in Italy, anywhere. That is good news because the dermatologist here doesn't have to learn to read these images. Good for the dermatologist, right? But this is advantage. However, it has limitations. The whole point of optical imaging is basically bedside diagnosis and immediate management. But is it possible with store and forward method? It's really not possible because even if the expert will get back to you in 2-3 hours, by that time patient is gone, right? And your technician who has taken the images, hopefully he's a trained technician, has spent a lot of time and is very knowledgeable where to acquire images. The technician may send bad quality images or inadequate images to the expert, which expert says, hey, I don't know what are you sending? I cannot make a diagnosis, right? So these are some examples from confocal because I do a lot of confocal. You see here, there is an artifact. This is not even touching the skin. There's other imperfections there. And with confocal, it's more complicated because we take one layer at a time. So sometimes technician might have missed a critical layer like dermoepidermal junction, and these images go to an expert reader and then say after 2 days, oh, I can't read these images because there's no DJ. How can I say there's basal cell carcinoma there, right? So everybody's talking about bad quality images, and this also impacts optical imaging even more because you really need to have some knowledge of these things. So to circumvent this situation, I started in 2019, just before COVID, with this very excellent dermatologist, Gennady Rubinstein. Trilok knows him very well, and he's my colleague and a very good friend at LA, in Los Angeles. He's a private practitioner, and we did a live remote control in vivo reflectance confocal microscopy session. It's a very complicated name. That was Jad suggested to change our name to live real time, so it is a long name. But the point is, I was sitting, and I'll show you the session. I was sitting in New York, Tarrytown, where I live. On a weekend, patient was scheduled, and this is how it happened. So the dermatologist, Dr. Gennady, actually, he scheduled a patient for teleconsultation with me. And obviously, images can be later sent for store and forward because they anyway goes to cloud. But instead of sending me via cloud, I was invited to join a WebEx session. And this is where I'll show you the next slide. And hopefully, my video will play. Okay, so here I'm sitting in my my home in Tarrytown, Westchester on a weekend. He scheduled the patient. What he did is he shared his screen. So all the screens, all these microscopes have screen. And that's the beauty, and that's why it's so easy for doing teleconsultation. and I'm seeing the screen in real time. I'm actually interacting with the dermatologist. I say hello to the patient on a video call, and everything is happening in real time. I'm taking control now of the screen, and I can guide the technician, hey, where to look for, because they're very confused. Okay, what are they looking at? Where they want to take meaningful images? They're very confused about it. So the whole beauty of this is, I'm not going to show the entire video. See how images look like, and you have to go and fish for your areas of interest in these big quality images. I'm trying to forward it, but it's going there. But anyways, so this is how we are taking images in real time, and I'm actually giving all the time guidance, and it's coming to an end. And the best thing is, I could give a diagnosis there and then. It was benign, it was an EY, and everybody was happy, patient was happy, management was taken care of there and then. Nobody had to wait, and this was great. So we had a lot of satisfaction. Obviously, the goal of this method is to train technicians also. They don't know where to take images, how to take images, and it's very critical in first 6 months unless they really get trained, you know. The second is obviously the physicians who are starting, they want to learn confocal, but obviously you can take out the books and atlases and you can do, but when somebody is teaching you in real time, that's the real thing. I wish I had that guidance when I started. Requirement is obviously high speed internet connection. And also, you have to be mindful that if you're asking an expert to do it, he's in similar time zones. I don't wake him up at midnight. But maybe your expert is happy to get up at midnight and do it for you. Advantage is obviously, it's like you get good quality images, you have seen the patient, you have interacted with the whole team, and the diagnosis is given there and then at the bedside, avoiding repeat visits from the patient, right? So this is very useful. Now COVID happened. As everybody has been talking about COVID, after 2020 COVID happened, and I said, okay, now what to do? I'm in Westchester, my trains are all like a crazy schedule, how do I come? So this is my technician, Eucaline Harris, who I trained very well before COVID happened. She's very perfect. So they are trained technicians. And this is Larissa Pastore. She's a medical student at HOPOC. So we have multiple satellite of Memorial. So Dr. Margoob, who specializes there at HOPOC, has a high-risk, very heavy clinic. And so we said, okay, let's do this study. Let's see if we can integrate this real-time tele-RCM in clinical practice at MSK. That would be great. So during 2 years, over 2 years, and remember in 2020, we had patient load went down regardless because patient had to still come to the clinics for this. We enrolled 156 patients and 191 lesions. And we imaged using confocal, either with handheld device or with the wide probe device. And we recorded the total imaging time because we wanted to see it's clinically feasible. And we also took patient satisfaction. We wanted to know how patient feels like at the end of the day. And these are some questions that we asked the patients. And I'm going to go into detail of that just to be in time. And some of the results. So we had average time of 16 minutes plus and minus 5 minutes, which is a very acceptable time. Remember, during that time, dermatologists can see another patient. So you are only with the technician and expert. So it's not delaying any workflow for the dermatologist. He can leave. Even a student who knows how to attach the device can start imaging under the guidance. This was our demographic, and lesions were located all over. So we had to take images using either of the scopes. And the patient satisfaction on all categories were very high, between 4 and 5, which was very exciting. Patient felt very happy seeing me and talking to them, and then we are talking to dermatologists. And of 191 lesions, these were all at the bedside decisions. 12 underwent treatment, cryotherapy or topical. Most of them actually were monitored, as you can see, and we had different monitoring intervals, and some of them actually went for biopsy. And these are the outcomes. And finally, we showed this that RT tele-RCM is clinically feasible, which was great. We saved 50% of biopsies in suspicious lesions. So these were difficult lesions, and especially most of the cases were Dr. Margoob's cases, who's a dermatologist, expert dermatologist. So not easy. When he's not sure, he'll say, do confocal. So these were not easy cases. We saved 50% of biopsies in these lesions. And this approach was very acceptable from the patient point of view, as we saw from patient satisfaction, and immediate diagnosis and management was done. So with this, I would like to say that this approach opens the door to wider diffusion of RCM in clinical practice. Now, actually, I'm trying to do a multi-center study, doing also in different countries. So we have collaborators, some collaborators in Europe, some in Latin America, and we'll see how this will go, hopefully in similar time zone. Now, I showed you that RT teleconfocal is helping with optical imaging, especially giving an example of confocal microscopy. But what about other optical imaging techniques that are coming up? Can it also help there? And it's important to know. And it's a same principle, right? This is one of the microscope. These are multimodal devices now they're coming up. And I'm just giving a little bit more flavor of optical imaging because that was my talk, and that's what I specialize. So this device, actually, only we have at MSK. This is a very nice device. It actually combines OCT, which is optical coherence tomography, with confocal microscopy. So at the same time, you're seeing vertical section as well as en face section with cellular resolution with confocal. And this actually has increased quite a lot of specificity, especially for basal cell carcinoma diagnosis, and this is great. And it has a screen. So far, you have a screen for live streaming, and you can have internet connection. You can always use it for teleconsultation. So my point is, can we expand this approach to other techniques? And yes, there are other devices which are high-resolution OCTs here, which is great. They actually start giving you cellular resolution instead of you see the conventional OCT doesn't give you cellular resolution. And this device is also very interesting. This is actually multiphoton. My love for multiphoton goes way back when I was in urology. And multiphoton is a very exciting technology in itself because with multiphoton, different tissue types can be excited at different wavelengths. And like collagen, as you can see, has a very specific signal. And this, you can tease out all this. Collagen looks different, epidermis has a different signal, and then it's combining it with RCM. So these all techniques are coming, but the bottom line, again, it is a screen. And this will become even more complicated for experts to read because there are so many signals they have to understand at the end of the day. Not for the experts, sorry, for the novices. So they would need expert guidance. But then again, the screen can be shared and done. And with this, actually, this is my perspective, how it can help me. Like this, I'm giving an example from India. I'm originally from India. So everybody has a cell phone now. There are engineers who have made smaller iPhone devices. And I wish in future I'll be sitting at the beach and not sitting at home and doing teleconsultation. So I'm very excited about this procedure. And I would like to bring your attention, if you want to learn more about confocal, I would like to invite you all to Memorial Sloan Kettering Cancer Center in New York. And it is during autumn. Dr. Margoob is going to give some dermoscopy course, a short course, and there will be a lot of confocal being discussed. And with this, I would like to thank everybody for their kind attention.